Welcome to the Evolving Past Alzheimer's podcast, where we are focused on bringing you information to help prevent and reverse brain diseases like Alzheimer's and other dementias. I'm Dr. Nate Bergman, a functional medicine physician in Cleveland, Ohio, and your host on this journey. So, whether you're a baby boomer who's worried that your brain wiring just isn't working like it once was, or you have loved ones with the disease, or you yourself have already been diagnosed and are wondering, what do I do now? You'll want to listen to this podcast. Each episode, we introduce you to the top doers and thinkers that are revisioning Alzheimer's and dementia. If you have questions or comments or just want to connect, please check us out on our Facebook page, or if you're old-fashioned like me, Google Evolving Past Alzheimer's Podcast, and you'll find us that way. So here we go. Let's get better. Welcome back to the show. I'm really excited about our guest today. We have with us Dr. Mary Ackerley. Dr. Ackerley is the Harvard and Johns Hopkins trained board-certified psychiatrist. She holds active medical licenses in Arizona and Florida. Mary is also a co-founder of ISEAI, the International Society of Environmentally Acquired Illnesses. Society members are dedicated to researching and quantifying symptoms and treatment approaches from biotoxin-mediated inflammatory illness. Mary's probably most well known for her internet article, Brain on Fire, which is a summary of neuropsychiatric implications of biotoxin illness, and her practice, My Passion for Health, is located in Arizona. She was also a co-author on an article with a previous guest, Dr. Dale Bredesen, called Reversal of Cognitive Decline in Alzheimer's Disease. And this was sort of an expose of a novel concept called Inhalational Alzheimer's. Welcome to the show, Mary.
Hi, I'm glad to be here, Nate.
So we've had a lot of my teachers on the show, and Mary's yet another teacher. I consult with Mary on difficult cases that I certainly can't crack. So I'm happy to get Dr. Ackerley on the phone and help solve the case.
Thank you.
Mary, the first thing I wanted to ask you about is the concept, the notion of inhalational Alzheimer's that's Dr. Bredesen's writing about. Do you agree with the notion of inhalational Alzheimer's? Would you frame it that way, or?
I like that word because it focuses on the fact that toxins come in through the nose, and the nose is very close to the brain. And it's sort of easy to understand that it's an inhalational process, or inhalational toxicity is a good word, and leading to real cognitive issues. So it's something people can understand pretty easily.
So you said toxins. When you say toxins, inhaled toxins, what are you referring to specifically?
Mycotoxins would be the first. Those are the toxins molds make to protect themselves, and they are pretty toxic. In fact, in the state of Arizona, trichothecenes, which is the toxin that Stachybotrys makes, is classified as a biowarfare weapon. So it is considered quite dangerous if a terrorist were to unleash it, but when it's growing in your bathroom, it's considered no big deal. I've always found that odd.
Right.
Oh, right.
Oh my God. For sure. When did you first notice cognitive symptoms specifically being related to mold and biotoxin exposure?
Probably some of my first patients. In fact, one of the first ones that I've talked about before, when I started to take mold seriously, I think it's 2010, was someone I'd been seeing for a while for depression that was somewhat difficult to treat. But on this day, she was like half an hour late for the appointment. We called. She couldn't find her way to the office. She'd been coming there for several years, and she was absolutely lost, and gave her directions and got here and got a story like what's happened, because she couldn't give me many details. And I thought I was going to have to call actually her kids and say, we need to talk about care. But she calmed down a little bit and she gave me a history. She was remodeling her home, and she said she didn't know what happened. She was noticing since she'd last seen me, she had a rash on her legs and she had to go see somebody. She had all this GI upset. They had done a GI workup, although she had all this abdominal pain. No one could find a cause. and that she had noticed her brain wasn't working that well. In fact, I wasn't the first doctor she had gotten lost to. And I said, has anything happened with this renovation? Well, they found mold in the whole ceiling, and I think they took it out. I said, well, did they use, some sort of precautions? No. I said, oh boy, I think I have a mold toxicity case, because I'd heard about mold. I just really thought it was, to be honest, like any well-trained psychiatrist, psychosomatic. And so, right? I mean, because we're told mold doesn't hurt you, therefore someone's claiming mold does hurt you. It must be
psychiatric. They're crazy.
Yeah.
Must be crazy. Yeah, sure.
Right.
Sure.
So, and that attitude still persists. But with this patient, I said, look, I'm just learning about mold. Here's a book. It was, Surviving Mold. We look through the symptoms. She says, oh, I absolutely have that ice pick pain, and pointed right to her temples, and I have the rash, I have the stomach. I said, you really have the cognitive issues here too. And I started her on cholestyramine because it seemed fairly safe. And I saw her back in about 3 weeks, and she could find her way. She felt better. The rash was gone. And her mood actually was a lot better. I was like, wow, all of this is hard to treat, but especially the cognitive decline. I was very impressed, and that's what got me started. So it would have been the first case I saw really of inhalational toxicity.
Now, was that the case that was covered in the article with Dr. Dale Bredesen, the reversal of cognitive decline in Alzheimer's disease case? No?
No, that case was probably about 5 years.
Can you tell us a little bit about that case?
It was a woman in her 50s who had the onset of depression, and then the cognitive decline became noticeable in not being able to do things around the house, take care of the activities she'd taken care of. And it became serious enough that they went to see Dr. Dale Bredesen. And they were referred to me, and her markers were positive for mold. There were hormonal issues. There was probably some, triggers and stressful triggers that had gone on too. So there were a number of things. And I started treating her for mold, or doing really, I guess, the Bredesen protocol, it's called now, with hormonal and with mold treatment. And there is, at the end of mold treatment, when you are getting out of exposure, and we can talk in more detail about ways to approach it, a natural hormone called BIP is used. It's vasoactive intestinal peptide. And it does have properties. It's been studied for the lungs. It relaxes smooth muscle. But in the brain, it had been studied as being able to remove plaque and to seemingly improve some cognition. And it's something that I certainly had noticed before, that people would say my brain is working better. And in this case, her brain began working well enough that she was able to start understanding what she read again. And it was pretty significant. It was significant for me because I had become so used to seeing people with severe cognitive issues improve. I just had not been putting it in the category of Alzheimer's or dementia. It was, in fact, when we saw Dr. Bredesen, some other mold doctors and myself had Dr. Bredesen at one of our conferences, he talked immediately about losing the sense of direction, of position in space as one of the earliest signs. And all of us looked at each other and thought about how common it was for us to have a patient who would forget how to get here despite having GPS and not be able to find their way to an office. So it was a reframing for us that was considered a serious symptom. To most of us doing this, it's fairly common.
Yeah, absolutely. I think that is a good question. How do you know that something actually is Alzheimer's? And it may be an academic distinction, is somebody suffering? Alzheimer's carries with it a whole different weight because, of course, the convention is still that it's
irreversible.
Irreversible. So from my perspective, just in kind of where I work and what I do, I think it's important to demonstrate whether or not this is actually Alzheimer's from a human being's perspective, from my patient's perspective. Really, the only thing we care about is if they get better.
Absolutely.
So I think You mentioned this whole, like, how do we know somebody's sick? How do we know somebody's sick with mold-related illness? Dr. Richie Shoemaker's put forth the concept of CIRS, C-I-R-S, chronic inflammatory response syndrome, as you well know. And other people have gone in different directions with mold and biotoxin related illness, sort of extending some of Dr. Shoemaker's concepts, and others have gone in different ways. In terms of making a diagnosis, like how do we know somebody has mold-related illness, particularly the cognitive impairment piece, I understand you can broadly break it up into elements of symptoms, MRI findings, like brain MRI findings, labs, and perhaps maybe another category like cultures. What are the basics for you? I mean, what are the basic things, the elements that you look for to make a diagnosis of this mold-related illness?
Symptoms and history. I think that's where you start. One of the most common histories I get is I've been to see many doctors. I've been given multiple diagnoses. Some of the treatments might have helped a little. Most made me worse. And I am really no better than I was when I started. That's a history of somebody with multi-syndrome illness. And the most likely causes are going to be at that point mold or Lyme or both. Those are the kind of illnesses that are missed routinely, cause havoc everywhere, and frankly, usually cause most patients to get referred to psychiatry, usually by doctor number 4. Is when somebody says, nobody's able to help you. We think this is psychiatric. And if people keep persisting, they will keep being told statements like that. Right.
An antidepressant. Right.
In fact, a doctor patient of mine who suffered from this illness for many years before he ever found out what the real causes were, when he found out, and I have to realize he was so sick, I actually met him in a nursing home and followed him into hospice. Wow. He was really ill, and it had been a gradual decline, but to the point where he was just, actually his whole body was on fire. He was not able to tolerate anything, smells, sounds, light, food. And again, he wanted to gather through his records. As I said, I think this is mold. Is that he gathered all his records as he got better, because obviously you only get 6 months of insurance in hospice. If you don't die, you're kicked out. Right. So it's good news. And he is better, and slowly. Yeah. And right. Very dramatic. He went and gathered all his records from all the doctors he had seen through about 10 years of conventional doctors in the Arizona area, California. And he gathered everything that had been said about him. And I have a list of all of them, but the one that really sticks with me is somebody had written in his chart, I think a neurologist, "Nothing here psychiatry can't cure." And this was to another doctor that this was said. So that's the way it's usually handled. So you're asking, how do I make the diagnosis? As I hear a story like that, my mind is going there pretty fast, and I'm already thinking, let's talk about the environment. Have you noticed water damage in your home? And a lot of people don't know what that is, talking about leaking roofs. And in Arizona, none of this is considered very important because it's thought it all dries out. So you have to do a real reframing. So it's history. Sometimes people, now that we have a lot more on the internet, people don't take quite so long to get a diagnosis, but they come in and I look at their symptom checklist and we have like 20, 30 symptoms checked. Again, it's not psychiatric, but it's not a definable illness that's easily diagnosed. And we're thinking about mold or Lyme. And then making the diagnosis involves usually looking for inflammatory markers. It's an inflammatory illness. I think I and other doctors are becoming more interested in using mass spectrometry of urine samples, which is getting more accurate, and looking to actually diagnose mycotoxins in the urine. which is another way to go about it. So you have a combination of things. You have symptoms, you have a history that's very suggestive. You try and confirm it with some diagnostic, inflammatory, and hormonal labs. And usually when all three pieces line up, it's pretty easy. Sometimes it's not quite as clear.
So let's talk, you mentioned the labs.
Yeah.
The labs that you use, let's say just the blood labs, without the urine mass spec testing yet. What labs do you find are most useful?
For me, the most useful that I can get most insurances to cover, and that's an important part of all of this, is the transforming growth factor. It's a cytokine, an inflammatory cytokine. It regulates autoimmunity, among other things. It has, by the way, been seen to be high in spinal tap, cerebral spinal fluid in patients with Alzheimer's, and in the brains, actually, I believe, with Alzheimer's. So it has been associated with Alzheimer's, among other illnesses. And that one is one all the insurances pay for, and it can be followed over time. And you can usually see as it goes down, a person's getting better. Like MMP9, matrix metalloproteinase, it essentially liquefies a person from the inside out. It just takes inflammation from the blood vessels, sort of eats holes in them, and allows the inflammation to spread into the tissue. And it's going to loosen the blood-brain barrier around the brain. And it's associated with pain. One of my patients a long time ago nicknamed it more and more pain. And that's how we remember it here. So
more and more pain, MMP.
And when those two are elevated, people always say, could it be anything else? In general, Lyme and co-infections may be contributing. People are always worried about cancer. It's not necessarily, they could be associated with cancer, but usually not in the other patterns we're seeing. So they're non-specific. But when they're high, they give an explanation for many of the symptoms. The inflammation is essentially spreading throughout the body, through the bloodstream, and whatever organ it happens to be closest to or might be weakest is going to be showing symptoms. So it starts to make sense of why are there so many symptoms in so many different organ systems, essentially, which is what confuses most traditional doctors. I like VEGF, vascular endothelial growth factor. It's usually low. Sometimes it's high, but again, never high enough that you actually see it in the cancer range. When it's very high, it is associated with cancer. When it's low, it's certainly associated with chronic fatigue because it enhances capillary growth to the extremities, the hands and feet. The biggest one, it also enhances blood flow to the brain, which is my area of interest too. So when it's low, it has been associated with depression and even suicide. And learning that helped me explain why I did see so much depression and suicidal ideation, inhalational toxicity. And again, when you have decreased blood flow, it's not helping cognition. So it's a very interesting and useful one to measure.
How about complement 4A, C4A?
I like C4A. It's become hard to get. In Arizona, it hasn't been done since 2013 correctly. So it is quite useful as showing that the innate immune system complement has been initiated and is active. And the higher it is usually a very good marker for current exposure. And it's done by National Jewish, and you can still get it. Quest has had issues with how it's done. You can get it done directly at National Jewish, but it's made it harder or more expensive for many patients to get it. But when you can get it, it's a great marker.
Okay, and MSH, melanocyte stimulating hormone, is that a useful one?
It's probably useful in the diagnosis. It explains some symptoms. I don't find it as useful because it's almost always below what the old cutoff used to be, 35. And honestly, even with treatment, it doesn't increase at the rate people would hope because they're led to believe it's controlling the whole pathway. And yet I don't have any surefire way doing everything that promises it's going to go up. So it's useful, but if people are really limited paying for this on their own, I may not measure it.
Okay.
We also don't have enough information really as a hormone, what happens after menopause or andropause as people age. In the normal population, does it go down? I think some of us suspect that there is some age-related changes too.
Okay, yeah, that's a good point. Like every other hormone goes down, so why should MSH be an exception, right?
Exactly. And does that contribute to why you don't get it up?
Interesting. And then one other question, one of my partners actually wanted me to ask this, and we often hear that transforming growth factor, so TGF Beta 1, is elevated in a mold-related exposure, or others like you mentioned, but sometimes TGF Beta 1 can be low. Is there any significance to a below the range, below the limit of normal TGF Beta 1?
This is some of the darker side of all this lab testing, is they are very easy to do incorrectly, especially if you don't have your own phlebotomist drawing them for every time. So usually when I see it low, I think somebody's done something wrong. And so there's no significance that I know of. It's usually a marker for me that we're just going to repeat it. And it's the same when the TGF is just too high. In Arizona, at least over 20,000 would be pretty unusual. Other places in the country may go that high because there is more mold. But when I see it over 20,000, I repeat it before I really totally put my trust in it. So I always say with labs is you're looking at patterns because you can never be quite sure, especially if you're just using phlebotomists who are, working for LabCorp Quest, that phlebotomist and their backup crew did everything correctly. They get paid by time and the amount of people through, and these labs take special processing and care. So I think that's the caveat. Is you ask me, is this diagnostic? I'll always say, if I see it like twice of the same numbers or close to the same numbers, I feel much more comfortable.
And how about you mentioned the urine mass spectroscopy tests. Can you talk a little bit about those, what you're using and how you find those useful?
I have not been using them yet, but I see patients with them. I'm involved with a group of doctors, some who are actively using them, and I'm planning to start using them more. I'm impressed that the techniques they are using are very specific. In fact, it's the same technique that they use, I think, in the Olympics to measure, drug testing for doping. So they're highly specific. And the cases I've seen where people have had them done by others have really corresponded to when you go further in the process and you get testing for where's the mold is, I'm seeing ochre toxin, for instance, with people who have high Aspergillus penicilloides. And one of the advantages of all of this is when people have insurance, you can get a lot of labs. And if they get something drawn wrong, getting it redrawn is an inconvenience, but it's not a monetary hardship. When people don't have insurance, which covers the lab testing, which certainly happens more and more, I'm looking for what's the most cost-efficient way to do this. And so I'm very curious if we can do urine testing that appears to be accurate. And so far, no one has been able to show that the testing done, that the results done by Great Plains using the mass spec are incorrect. That would seem to me a better way to go. So I'm changing at that. There are other urine tests that have been available, and there's so much debate over their accuracy because they're using really antibody type testing that is not totally specific, and it's also twice the price. So that's my reason when people ask me why would you use one, not the other, is I think you have a good chance if you see a positive with Great Plains that it's real, and then you can go on. But I still like labs because it gives me a measure of how ill a person is. You can have toxins in your body, but not necessarily have illness. There are some people who are just excreting the toxins and their body is handling essentially the irritation or the inflammation without becoming systemically ill. So I find that for following the illness, I really do find it useful to watch these cytokines go down. Feels very reassuring that we're getting somewhere.
And again, that's so good. Again, for our listeners, the cytokines being things like C4A, complement 4A, TGF Beta 1, MMP9. These are the cytokines that Dr. Ackerley is referring for. Okay, excellent.
So I see a place for both, and I'm giving you the grays here that in the real world, most people don't have insurance to pay for everything. And because this can be an expensive illness to treat when you take into remediation, you want to be, I think, responsible with people's money and try and do the best you can without using all their resources. So that's my clinical thinking about it.
And I just talked to somebody today. She moved out of her house and had to move back in with her parents. She's like 40 years old. I mean, it's just like her life is upside down right now while she gets on the mend.
Well, yes, that would be pretty normal. That's why we have very strong mold support groups here in Arizona, in Tucson. In fact, one of my original patients, husband and wife, who I saw right after the first patient, run the mold groups here, and they've been through all of it several times, unfortunately. And they run the groups, and then in Phoenix, we have a very supportive group, and they're online, which helps people around the country join in. And I also refer very liberally to the online support groups run by Patty Schmidt, who's been doing them for a long time for people who start to feel very isolated and alone with this illness. So we can talk about that, but I just want to say that they are really good resources for what often happens.
Yeah, no, Patty's work, I know just a little bit, probably from the same way you do, and that's, she's have a lot of respect for what she's doing. Let me ask you on a different side. We had last year Dr. Cyrus Raji on our program, and he talked about volumetric MRI software. So meaning that's essentially a computer program that automatically measures different areas of the brain and tells you whether this part is normal, larger, smaller than average, basically. There are a couple commercially available softwares out there that are FDA approved, NeuroQuant and NeuroReader. I know that you are somewhat of an expert in terms of the clinical interpretation of these brain MRIs when they are measured by one of these softwares. Do you use one in particular? Do you like both? Do you like one, either NeuroQuant or NeuroReader? Do you have a preference, and why?
My preference is NeuroQuant, again, just because in practice, it's much more available than NeuroReader is. So I don't think we have any doing it in Arizona. Getting it established requires then a lot of convincing of different radiology departments, et cetera. I see NeuroReaders when people bring me them. They've been done because they're getting dementia workups. And I know there are some differences we can talk about. So in general, my experience is really with NeuroQuant over the years. And I'm very happy for the most part with it because it gives me at this point so much information that as a psychiatrist or as a neurologist, you can only dream about seeing that much detail about very specific parts of the brain.
Yeah, so what do you see in the brain? Like what patterns do you see in the brain in a mold-related illness? I mean, I'm sure there's several, but can you speak to some of the patterns that you see?
I think that's changing as to what we see. NeuroQuant report, which has, I think, about 50 different centers in the brain. Mm-hmm. So there's a lot more detail than some of the original studies perhaps had. And the ability to use age and sex match controls has really refined what we see. Yeah. I'll actually say that in my patient population, one of the most striking findings I see is the thalamus enlargement at like 95% or more, and often the amygdala enlargement. And that is so easy to see that I could almost do, a study by hand of this is very associated with at least my patient population. And I've had a couple of other doctors say the same thing. So that's a lot more refinement than was available, say, a few years ago with other studies.
What about areas like the caudate, other areas in the deep brain?
Yeah, definitely. I see the basal ganglia affected, the most metabolically active part of the brain, I'm told. So it is where toxins like heavy metals and presumably mold will end up. When you look at very specific measurements, you can see that sometimes the caudate is showing 2 standard deviations below norm for age and sex, but sometimes it's not the caudate. Sometimes I see it's the putamen, other times the globus pallidus. So I can certainly see atrophy in different parts of the basal ganglia, but I don't see the frequency with caudate atrophy that might have shown up in earlier studies at all.
Interesting.
I think it would be easier to say the basal ganglia can often show some atrophy, severe atrophy.
Interesting. So using the NeuroQuant Triage Brain Report is useful to you, and you are seeing also, you said, amygdala enlargement. Now, amygdala enlargement is found in a number of different illnesses. I believe, like PTSD, post-traumatic stress disorder, you see amygdala enlargement. I think they're seeing some signal near there in chronic fatigue syndrome. I think there's a group out of Stanford that's reporting on that. It's not just the amygdala, it's actually an area, sort of a sub area within the amygdala. But are you seeing the overlap there?
I am seeing certainly the amygdala. And when I said in my patient population, I meant somebody who is willing to see, wants to see a psychiatrist because they know that there is a component going on that has been called PTSD, maybe called anxiety. I often just call it sensitivity. And I think my patient population at this point is very geared to people who have greater sensitivity than many others for several reasons, of which one is simply the hypermobility Ehlers-Danlos component. So these are people, it's very easy to say, I don't know if you've talked about amygdala retraining on the show before, but I can say at some point your amygdala is in the 99th percentile. I think you can see that dynamic neural retraining is going to be useful. And we can laugh. It's not a judgment. It's just, hey, it's the fire alarm is set. It's ticking on specks of dust here, okay? And we wanted to, have you avoid rattlesnakes, but you should be able to tolerate mosquitoes, and that's what the retraining is about.
So that's our episode. I hope you guys got something out of that. Check the show notes out on iTunes or on our website where we've summarized the key points. If you have questions or comments or just want to connect, please check us out on our Facebook page. Or if you're old-fashioned like me, Google Evolving Past Alzheimer's Podcast, and you'll find us that way. Finally, if you find the information here valuable, please consider giving us a 5-star rating on iTunes and leaving comments in the comment section. It will really help us bring this message to as many people as we can. Thanks, and talk to you next time.